Hi everyone, my name's Jenny Fitzharding. I am a volunteer for Family Connections, and before we get into everything, I just wanted to do a quick acknowledgement of country. In the spirit of reconciliation, NEA BPD acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples here today. So just a quick overview of what NEA BPD is, or the National Education Alliance for BPD. We are a not-for-profit organisation that supports families and carers of people living with a personality disorder, which can affect up to 17% of the population. We're a volunteer-run organisation with over 200 volunteers right across Australia helping us out. And we're one of 26 countries around the world that offers the Family Connections program. Family Connections is a 12-week evidence-based program that provides skills and hope to family members and carers. The program is offered free of charge to participants and is led by our volunteer leaders who generously give their time to support other families. We don't receive any government funding, and we've relying solely on donations. So anyone that was able to make a donation for this webinar, thank you very much. We really appreciate it. It helps more than you can know. Today, we are very honoured to have Dr. Reem Ramadan talk to us about the intersections between borderline personality disorder and eating disorders. It's a complex relationship, and this session is going to explain why these two conditions coexist, how BPD can influence eating behaviours and vice versa, and the unique challenges that this presents for individuals, families and clinicians. And we're going to cover some effective evidence-based approaches to assessment, treatment and support for those navigating this challenging intersection. Dr. Reem Ramadan is a clinical psychologist and senior clinician at the Helping Young People Early, or HYPE program in Melbourne, Victoria. It's an early intervention program for BPD and and Dr. Ramadan also established the eating disorders team at HYPE. She's worked with young people experiencing complex and severe mental health difficulties for more than 10 years in public mental health services in the UK and Melbourne. Reem uses her clinical knowledge and experiences to assist mental health services and other organisations to identify and respond effectively to vulnerable young people and their families. Okay, so Reem, I'm going to hand over to you.
Thank you very much, Jenny. I'll just share my screen. Great. So thank you very much. I just also like to acknowledge the traditional owners of the lands. I'm here today on the lands of the Wurundjeri people in what we call Melbourne. And I just want to pay my respects to the elders past and present and acknowledge the care that they've been taking for these lands and waterways for tens of thousands of years. And also acknowledge the ongoing health disparities that Aboriginal and Torres Strait Islander people face. And this always was and always will be Aboriginal land because sovereignty was never ceded. And then I just wanted to give a little bit of an explanation. So people may have heard of Origin, and all my slides still say Origin because it's only been a couple of weeks since we've actually changed the name of the clinical program to Parkville Youth Mental Health and Wellbeing Service. So I'm coming to you from that service. It is still the same service as Origin was. It's just due to some of the Royal Commission recommendations, we've changed a little bit how we're aligned, but we're still doing the same things. And we're still very much connected with the research and policy side of Origin, which is very well known. And the HYPE team and the eating disorders teams now sit under PIMS, but we have that connection. So if anyone's particularly in Melbourne or people might be looking for things and kind of a bit confused, we've got slightly new branding. I didn't have time to update the slides though. So just a little bit of an explanation of who we are. So we are a public mental health service. We work with people aged 12 to 25 years and their families and supports. it's a quite a large area, quite a diverse area, and we treat all severe mental health problems through a range of different community teams, and also other programs, including acute and subacute programs like hospital in the home. We have a psychiatric inpatient unit. We don't have an eating disorder specific unit. We have to work with other hospital services in our area to work with them. And we also have a clinical training and community development teams. And part of my role is to work in the clinical training team as well as in the eating disorders team. And for about 12 years, I worked in the HYPE program as well and did training in the HYPE program. So as part of that, I really want to also acknowledge the people that we work with and their lived experience. And we very much value the insights and the experiences they give to us in our work and our learning and our research and our training. And it's a very important part of our work here at Origin is to work with people with lived experience, including families and carers. So thank you. Just do this. So I'm going to talk a little bit about eating disorders. And I think, what we know is that lots of people experience difficulties in relation to eating disorders. And so I guess when I'm talking about these things, I'm mindful that there might be people in the room who've had eating difficulties. But I guess that's because we know eating disorders are really common. At any point in time, 4% of the population have a diagnosed eating disorder. And the most common eating disorder is binge eating disorder. But a lot of the things that we see in a tertiary public mental health service is anorexia due to the severity and the risk of mortality. But as you can see, people with binge eating disorder are most common. Eating disorders are most common in females, but actually, sadly, the prevalence is increasing in males. And so we are seeing more men in our service. And the other kind of striking fact, I think, is that nearly a quarter of all transgendered young people have had a current or a previous diagnosis of an eating disorder. So it's really common in the trans community. So when we think about eating disorders, we actually think about it on a spectrum. So there are kind of people who have healthy body image and eating, and they kind of have a level of body acceptance, regular healthy eating habits, and a generally kind of healthy weight for their age, height, and body type. Yeah. And then there are, and this is probably the most common thing, people with disordered eating and body image. So they might be doing to some level and to some extent restricting or purging, so vomiting or using laxatives, steroid use, maybe fasting for periods of time. There's a strive for eating well, healthily, perfectly, or maybe looking a certain way, maybe engaging in excessive exercise and a significant preoccupation with how they look, and particularly their body shape and their weight. People might engage in compulsive overeating as well, and there's often a lot of yo-yo dieting in this group. And then we move over to the eating disorders, and the DSM-5, which is one of the main ways we think about eating disorders, has a number of eating disorders described. And the main ones we think about are anorexia nervosa, bulimia nervosa, binge eating disorder, ARFID or avoidant restrictive food intake disorder, and then other feeding and eating disorders, which is kind of a catch-all for a lot of people who are sub-threshold, who might not quite meet the criteria of any one of these four, but have a lot of kind of disordered eating that is concerning and causing harm. The other thing that falls into this group is atypical anorexia nervosa. There's a lot of controversy about that because what that is people with anorexia nervosa who are not underweight. So they engage in significant restriction. They've lost a lot of body, they've lost a lot of weight, and it can be really, really harmful, both medically and psychologically. But there is a criteria in anorexia about their BMI, and so they can't fall into that category. But in our service, we treat them exactly the same as people who have anorexia nervosa. So the key eating disorder features, and these are for everything excluding ARFID, is there's really strong sense of value and self that is dominated by control of weight, shape, or eating. So people really, really put an over evaluation on how they look and feel like they are worthless or not good enough if they don't look a certain way. All the eating disorders have a kind of disturbed eating habits. So that might look like restricted eating or really strict rules or really significant preoccupation with food. Regular eating is unlikely. People might be binge eating or eating compulsively, things like that. And the final category is disturbed weight control behaviors. So people doing what we might call compensatory behaviors. I'll talk a bit more about that in a minute, but doing things to kind of manage their weight. And that might be excessive exercise or vomiting or using laxatives or emetics, which are things to make people throw up, or diuretics to kind of manage their weight. ARFID is a little bit different. But can actually have some really significant consequences. So someone with ARFID will avoid or restrict their intake, not due to their concerns about how they look and their appearance and their body shape or size, but actually due to one of the following three reasons. So it might be due to restricted interest in food. That's what restriction means in this comment. So someone who has very little or no interest in food and eating. And that has to be something quite long-standing and not related to the way they look. Um, uh, I'm going to talk a little bit more about what happens when people are starved, and so it can show you that there can be a bit of a complication of working out whether someone's at ARFID. But when we think about ARFID, it's not something that's uh, that comes on, but it's actually someone who's always shown very little, or for a long time, ever since they were a child, shown very little interest in food or eating. Another thing might be the avoidance. So one subcategory of people with ARFID are people who avoid certain foods due to like sensory features of them. So there might be certain textures or smells or how they look or taste that might be really aversive to some people with ARFID. And so they really avoid foods like that. And so that can lead to a really limited intake in what they can eat. And the final subcategory is aversion. So people who have a fear of negative consequences resulting from eating. And usually what that occurs for people who, again, early in childhood, have had a really horrible experience while eating. So it might have been a really significant vomiting episode or choking or an allergic reaction, and that's made them really frightened to eat. And so you can almost consider it like a phobia, because they're really worried that something bad might happen if they eat, and so they're not eating. And so all of these things in ARFID tend to happen from an early age and then have significant consequences to someone as they develop. So what we often see is people lose weight, and or particularly in young people, because it does happen developmentally, they don't really achieve the developmental milestones in terms of weight gain and growth. But we do know that people with ARFID can present at any weight, particularly people who might be avoiding certain sensory types of foods but can eat other kinds of food. Often people with ARFID may have really significant nutritional deficiencies due to the limited kind of types of foods they can eat or limited intake that they have. And sometimes people need to kind of rely on being tube fed or something because they're not able to eat normally. And it can have a really difficult interfere with their psychosocial functioning. So the things that they do, because they find it really difficult to eat with people or only eat particular foods or take much longer to eat because they've got to eat really slowly to avoid a negative consequence. And that can really impact on how they function at school or home and things. But ARFID and other eating disorders all have kind of, particularly people who are not having enough intake, all can be malnourished, and that is a really concerning thing for people with an eating disorder. And there was a study done in Minnesota in the 50s called the Minnesota Starvation Study, where they took healthy young men and they reduced their intake and reduced how many calories they got for a period of time, and they observed what happened to them. And they found a lot of features that were really core to what we understand about starvation. So there were a lot of psychological things that they noticed, that people became very emotionally labile, so they had lots of mood swings, and they found it really difficult to regulate their emotions. They had anxiety, they had depression. Cognitively, they found it really hard to think clearly. They had really poor concentration. They found it difficult to make decisions. Um, and they got quite rigid in their thinking, quite obsessional in thinking, particularly obsessional about food. So people who were starved really thought a lot about food. Um, and that took up a lot of their time. They also found it, they were less alert, and they found it difficult to comprehend, particularly kind of more difficult things. Physiologically, what they found was that people who were starved were felt cold all the time. They had dizziness, blackouts. They might retain fluid. They found cardiac complications. They found they became weaker, and they had hair loss and dry skin, and they were very, very tired. And socially, what they found is that people, as they became more malnourished, became more withdrawn. They isolated themselves. They had lost their sense of humor. Their relationships became more strained, perhaps because of some of the psychological and cognitive factors. They spoke about feeling inadequate socially, and they started to neglect themselves more comprehensively. So they weren't just not eating, they would started to neglect their hygiene and things like that. And the reason this study is really significant is because all of these people were healthy before their intake was reduced. So these are the symptoms solely caused by starvation. And they're really common symptoms that you see with people with eating disorders. And so sometimes it can be really hard to know what is due to the malnourishment and what is due to other psychological factors. So this diagram is pretty small, but it's a really helpful thing that we use with some of the people that we work with to kind of go through all the different areas that might be impacted by malnourishment. So a lot of the symptoms people talk about in terms of feeling depressed or anxious or isolating themselves, they might see it as a part of a bigger problem, but sometimes a lot of that might be due to malnourishment. Also helping people understand that they're not just losing weight, they're actually damaging their organs and their muscles and their bones and their joints. And that's partly where the weight loss is coming, is that they're actually causing damage to their body, not just losing fat. And so we talk through that. We also talk about how bulimia, so people who maybe aren't restricting, but who are binging and then purging in different ways to manage their weight, and what effects that can have on them. And as you can see here, there's a lot of different parts of the body that it can affect. And I think it's important to think about some of those physical symptoms as well as the psychological symptoms when you're working with someone with an eating disorder. And people who binge, but also people who engage in other eating disorders, usually have some sort of compensatory behaviors that can cause problems as well. So, purging is something that people might do. So, and that can have real risks in terms of the physical health, and can cause both in an acute way, but also in terms of a long-term way. And it also has a lot of guilt associated with it. So people can feel really ashamed about the binging and the purging, and get caught up in a cycle of binge purging that they can't get out of. Excessive exercise. So when we talk about excessive exercise, we talk about exercise that's more than recommended, more than adequate, more than equivalent to the intake that the people are having. So, if someone is training for is a competitive sports person, they might have to do a lot of exercise, but they also have to have a really large intake to manage that. And, excessive exercise in this context is when people are not eating very much and doing a lot of exercise, and also feeling very unable to stop themselves from exercising or feeling really guilty if they aren't able to do the exercise that they want to do. Water loading, and that might happen to kind of help people not eat as much as they want, but can really be quite risky in terms of the body functioning and can lead to kind of physical complications that can be very dangerous. People use laxatives, and that can cause permanent damage to their bowels, and it can also, depending on what the laxatives are, be kind of quite harmful in terms of the medication that they're taking. And diet pills. These are usually prescribed, but there's some available over the counter, and they can be harmful in terms of what's in the medication, but also in terms of what kind of patterns they're helping maintain in terms of the poor eating behavior. So one of the main things we know for what helps people recover is regular eating. And so establishing regular eating habits is a core part of eating disorder treatment, whichever eating disorder people have, and trying to get people to eat regularly to overcome that is a foundation. So it's a really important thing because I think our society has really normalized the diet culture. And we've got all of these ideas about what healthy, in air quotes, is. And actually, a lot of that is not accurate. And so it's something for us all to reflect on. And we certainly, I have done that as an individual. We do this as a team, as well as when we're working with clients and their family members about what information we've been told over all the years. I may be giving my age away, but I was growing up as an adolescent in the heroin chic era, where, being as skinny as possible was the most important thing. And, we know that young people nowadays are getting bombarded with social media messages and things like that. And what we're trying to say is actually a lot of those messages, most of them are really unhealthy, even though they claim to be healthy. And what we need is for people to eat regularly in order to recover. So there are lots of treatment approaches available. And in eating disorders, they tend to split them up as for adults and adolescents. So that's how I've described them here. And these come from sort of NICE guidelines, which are kind of from the UK, but kind of used worldwide to kind of think about what some of the best treatments are using all the available research. As in everything, they're all acronyms, but there's a lot of CBT there, as you can see. So CBT is a really common treatment, and there are different types of CBT. So CBTE is a kind of transdiagnostic form of CBT for binge eating disorder, bulimia, or anorexia that's really effective. CBT GSH is guided self-help. So for binge eating disorder and bulimia, guided self-help can be really helpful. And there is a book that people can follow with the support of a health professional to go through and be treatment. For anorexia nervosa, CBTE can also be effective. The model that we use in our team is SSCM, which is specialized supportive clinical management, which is a bit more flexible than CBTE, but that's partly because we work with young people that are more at the severe end. And there are some models that are more commonly used in the UK, I would say. They're becoming more available in Australia, called Mantra and FBT, that have a bit more of an interpersonal focus. Something I haven't put down here that we've been offering is a temperament-based treatment for anorexia that involves, it's a week-long group program for young people and their families. So we've run it 4 times, and we run it with 4 or 5 families, including the young people, that focuses on some of the temperamental factors. And I think that's important to think about when we start thinking about the intersection with personality disorders. And I put question marks by these because they're not in the guidelines, but there's a lot of emerging evidence for things like DBT-RO, which is a type of DBT that's being kind of developed for people with eating disorders and anorexia specifically, and CAT, which you may have heard of if you've been to talks that people from the HYPE program have done before, because it can also be helpful for people with BPD. ARFID, there's a treatment called CBT-AR that's being developed, so a type of CBT that's specific for ARFID. For adolescents, there's a bit more focus on family involvement, so family therapy, which is what the FT stands for bulimia and for anorexia. FBT is a version of FTAN that's for anorexia too. And then the CBTs are still for some adolescents helpful. And for ARFID, again, it's CBTAR or FTAR, so a kind of family therapy focus, but more on ARFID. There is a real there's a lot more family focused work in eating disorders work around meal times and things like that. And so there's a tendency to focus on that as the first line treatment for adolescents. What we know about eating disorders is they have really, really high levels of co-occurring conditions. So there's high level, up to 97% of people with an eating disorder have a comorbid condition. And the most common ones are depression and anxiety and substance use disorders. But up to nearly 60% of people with an eating disorder can experience a personality disorder. So there's really, really high rates of personality disorders, and the most common personality disorders are BPD or OCPD, so obsessive compulsive personality disorder. Diabetes is also a concerning co-occurring condition in eating disorders, which may complicate an eating disorder. So it's also something that we think about. I'm only going to briefly talk about personality disorders here, partly because I felt like I know that NEA BPD has lots of webinars on personality disorders, and because one of my colleagues, Louise McCutcheon, recently did a talk on personality disorders as a webinar for the Family Connection. So I encourage people to go back and look at that if you want to know more. And I know there's a lot of information out there. So I'm tended to talk a little bit more about eating disorders here just in this presentation, and I'll then go on to talk a little bit about how the two are related. So how do we currently define oh, sorry. Yeah. How do we currently define personality disorders? So I think most people are really aware of the different types of personality disorder, with BPD being one of the most common, and severe personality disorders, but we're actually moving away from a categorical way of talking about personality disorders to talking about them on a more dimensional construct. And partly that's due to the fact that we know that it's a developmental disorder, and people are kind of thinking about which are the aspects of personality disorders that kind of become more difficult and are not normative in development across the lifespan. So what we know about personality disorders is that people start experiencing them from a young age, and it prevents them from achieving some of the kind of functional and interpersonal relationship and self goals that they hope for, and most people hope to achieve across their life. And when we think about the dimensional model, we're really looking at how much impairment people have in terms of their representations of themselves and others, and their ability and capacity to connect with others and engage in kind of behaviors that help them have healthy relationships with themselves and others. One of the things that particularly the Hype Clinic, so we at Origin, have really been thinking about is when to detect and help people with personality disorders. So historically, for a long time, people felt like you couldn't treat personality disorders and you shouldn't diagnose them until people were over 18. But actually, a lot of evidence and research has shown that people can kind of assess for personality disorders across the lifespan and in a reliable and valid way. And we know that most of the clinically significant difficulties that people experience when they have a personality disorder start emerging between the ages of 12 and 25. And for people, more than 25% of the diagnoses of people happen between the ages of 14 and 22. And so we also know that people with personality disorders have a really high burden of disease, morbidity, and premature mortality, and people are not getting treatment early. And part of that factor is that a lot of people are reluctant to kind of diagnose and treat people early. And so that can be a real problem. And so one of the things that Andrew Chan and Louise McCutcheon and the Hype team have been doing is really promoting this idea that we can actually diagnose and people with personality disorders um, carefully and thoughtfully at a younger age, and then offer them treatment that can be effective and really help them set them on the right track for their as they're becoming adults. So we know that there's a lot of myths and unhealthy beliefs about personality disorder that is actually quite stigmatizing for people. But the evidence shows that you can diagnose people under the age of 18, and it's not that we're giving them a life sentence, but it's just meaning that we can provide treatment early. We also know that people with personality disorders are not just experiencing a normal adolescent phase, is actually something that can impact their lives ongoingly and into for a long time if not treated. And that actually people can be treated, and it doesn't need to be a long-term psychotherapy, but um, but it, personality disorders, particularly borderline personality disorder, there are some effective treatments out there, and we need to be targeting people's self-harm and supporting them to have better relationships with themselves and others, and then that can really affect how their lives go on to develop. So I guess I'm not going to go a lot into the treatments about personality disorders specifically yet, but I will talk about them when we think about co-occurring eating disorders and personality disorders, which is my next section. So how common is it? Well, what they found is, and a lot of the research I found was looking at personality disorders and how many people have an eating disorder. So hopefully that's relevant to this group. But I'm sorry, looking at eating disorders and how many people have personality disorders. There's less research on people with personality disorders and how many people have eating disorders from that. I hope that makes sense. So what they found is of nearly 3/4 of people with an eating disorder who are seeking treatment had a personality disorder. And that they found that once they had treatment, that decreased to about 25%. So that treatment can really help reduce people's eating disorder and personality disorder. We know that people with an eating disorder and a personality disorder often can have chronic difficulties, and they tend to have the highest level of functional impairment and overall morbidity. So it's really important that we do offer treatment to these people because they're really, really suffering, and it can have a really big impact on their lives. And some of the most prevalent co-occurring personality disorders were borderline, avoidant, paranoid, dependent, and obsessive compulsive. But I guess now we're moving towards a more dimensional model. I think we might be thinking about what are the features that make people, what are the things that make it harder for people who have an eating disorder in relation to their personality disorder. So what does it mean for treatment? We know that there's a relationship between personality traits and eating disorders, and there's research has shown connections between personality disorders and eating disorders in terms of their etiology, so how they develop, their symptom expression, and how the symptoms are maintained. So there's a lot of overlap in those factors. And there's also a lot of evidence to show that the influence of an eating disorder and a personality disorder are reciprocal, and higher levels of one are generally associated with higher levels of the other. One factor might be that malnourishment, as I talked about earlier, can really exacerbate some symptoms in relation to mood swings and emotion regulation and cognitive rigidity and things like that, which are also really common in personality disorders. So the kind of combination of the both can make the symptoms more difficult. And when and research has also shown when treatments targeted the personality disorder, the eating disorder outcomes were generally better. So I guess what we're saying is if someone has a co-occurring eating disorder and a personality disorder, eating disorder treatment isn't going to be as effective if it doesn't think about the personality disorder as well, which makes sense, I think, just on a common sense level, but the research also shows that. And so really treatments that address the underlying personality traits associated with the development of the eating disorder help treat both the eating disorder and the personality disorder. So how can we work effectively with eating and personality disorders. And in our service, we do have a lot of young people who present with eating and personality disorders. And so that's something that we've had to do. And part of the reason for that is often eating disorder treatment services won't work with people who have a personality disorder because they see the symptoms of the eating disorder as being part of the personality disorder, and a struggle had to manage that. So we in our service have always worked with people who, whether or not they have a personality disorder, we will support them. So what do we treat first? Often that comes up as a big question is, do you work with the eating disorder or the personality disorder? But actually most of the research shows that you actually need to address both in treatment. So in eating disorder treatment, often people are quite ambivalent. They, the kind of societal emphasis on appearance and all the messages that we're getting about how you look and what you're worth being really related to each other, plus kind of some of the coping strategies, like not malnourishment helps numb your emotions and things like that, mean that people really don't necessarily come to eating disorders treatment wanting to get rid of their eating disorder. They might want to get rid of other things, but they generally don't want to increase their weight or stop not eating. So that can be really hard. And if they have a personality disorder as well, which we know people with personality disorders can sometimes struggle in relationships, that kind of tells us that a really important part of treatment is to really think about the therapeutic relationship. And so treatment approaches that really focus on the therapeutic relationship are likely to be really important in people with co-occurring issues. And then what we know is if you attend to just the personality disorder symptoms, sometimes that can be a really that can be a way of avoiding eating disorder treatment. And so some people with an eating disorder and a personality disorder, and as I said, they don't really want to get rid of the eating disorder, can kind of really lean into the personality disorder symptoms. I want to focus on that as a way of not eating regularly. But one thing we know is that if we can help with the malnourishment side, that might help with some of the personality disorder symptoms side and the eating disorder. So what we don't want to do is just focus on the personality disorder and kind of avoid the eating disorder. The other thing we know is that if we avoid the eating disorder, potentially that person will become really medically risky, and that's a big issue in itself. We also need to kind of think about how the eating disorder symptoms serve to help cope with the personality disorder symptoms. So one really common thing that we find is as people start gaining weight, if they have anorexia, what they might start doing is then self-harming more if they've got co-occurring eating disorder and personality disorder. And really what that's kind of demonstrating is that people with are using their restriction as a way to kind of numb themselves and numb their emotions. And once they start eating more and starting to feel more, that means that they have lost that coping strategy and they go back to their alternative coping strategies of self-harm to manage those emotions, difficult emotions. So a really important part of treatment is understanding how the two are related and how the symptoms serve to cope. Eating disorder symptoms might help to serve to cope with some of the eating personality disorder symptoms. Because if we don't, then we're just leaving that person to have to, without any coping strategies, and they're going to go back to their unhelpful coping strategies, such as self-harm. What we do know is because there's a lot of transdiagnostic overlap and mechanisms between eating disorders and personality disorders, as we talked about, is that treatments that are a bit more transdiagnostic can help us think about both. So there are options available to us. And one thing we've been thinking a lot about in the service is what is common in eating disorder treatment and how does that relate to personality disorder treatment? So when we think about the really important elements of all eating disorder treatments, they require you to do psychoeducation. They really think about treatment expectations, engagement, and working with ambivalence, risk assessment, goal setting, monitoring symptoms, addressing directly the challenging eating behaviors and body image concerns, as well as addressing comorbidities and working with the care team in the system. And in the hype model, which you might have heard about if you've been to any of these other webinars, um, the things that we do when we're working with people with personality disorders is think about diagnosis and psychoeducation. We really think about the therapeutic relationship. We think about goal setting. We work with the symptoms and the co-occurring conditions. We work with the ambivalence and the motivation and manage that engagement and repair those ruptures in the relationship. We manage to crisis. And so when we're thinking about crises, we have to think about medical instability, and we're thinking about eating disorders as well. We involve families and supports, and we think about endings, and we support the team. So there's a lot of overlap between the core elements of personality disorder treatment and eating disorders treatment, as well as in the kind of underlying mechanisms behind what drives an eating disorder and personality disorder. So that's really positive. So I guess what does that mean in terms of treatment and how families and carers can support their people with an eating disorder and a personality disorder? So what we know about caring for someone with a personality disorder is that it's actually really personality disorders are really complex. There's lots of different factors that might lead someone to develop a personality disorder, and that families are usually doing their best, but often worry that we as clinicians might blame them. And we know that from research on families of young people with BPD that they often have little knowledge and they want to know more and worry about what to do and how to manage these really risky and challenging situations that they're experiencing. And we also know that limited knowledge actually can sometimes mean that problems get worse because family members don't really understand or reading from sources that are kind of very stigmatizing of people with personality disorders. And it can lead to like very negative communication styles, which makes things and ways of relating with the person that might be like high levels of criticism or getting really over involved, which then might serve to kind of make things worse for that person in terms of their personality disorder. So even though people are really trying to manage it, if they don't really understand what's going on, it can make things worse. And so when we look at interventions for families and carers and people who support people with a personality disorder, we know that actually treatment should help engage the family and support and family members from the start, help them to reduce their stress, increase the support they get, give them lots of psychoeducation, help them understand what are the normative tasks for young people and and so that we can get them back on track and understanding what is appropriate to expect from someone at that age and building skills to help them respond in an effective way with their loved one. And so, interestingly, it's a very similar thing when we're working with people with eating disorder and how we support carers. We know that carers of people with an eating disorder also experience really intense emotional reactions, and that can really disrupt the family system, especially around meal times and routines. And families can say everything centers around meal times because you're supporting someone often 6 times a day. And that can really be worsened by family members not really knowing how to support their loved one and their attempts to support them not being so helpful and that becoming problematic. So again, when we look at interventions for caregivers for people with an eating disorder, the focus is on psychoeducation, support, and self-care, very similar to what is important for family members of people with personality disorders. I found some quotes from people, parents of their experiences of caring for a person with an eating disorder, and in my experience of working with family members of people caring for people with personality disorders, they really resonated. So I thought I'd share some of them with you, so you can feel terribly isolated from your friends. I realized a lot of what I was doing wasn't actually helping him. I'm going on to antidepressants at the end of the month because it's just too stressful for me. And we used to have loads of friends come over all the time. And then my sons stopped inviting their friends around because they didn't know where the plates would be thrown or whether she would yell. So it's just showing again how difficult it can be to care for someone with an eating disorder and how isolating it can be for the family and uncertain it can be for the family. So when we think about supporting families of people with an eating disorder, we have something called the Collaborative Care Skills Workshop, which is an evidence-based 6-week workshop. The Butterfly Foundation, which is a really great organization in Australia, runs some of these workshops, but there are also local, I understand people could be coming here from around the country, but there's in different states, there's also options to join these workshops. And they teach family members and support family members and other carers to think about how they can care for themselves and avoid burnout while caring for their loved one with an eating disorder. They help people identify their caring styles and help them learn how to lean into that to support the person that they love, thinking about how to manage difficult behaviors and utilize skills to help that person in their recovery, and also providing a community that you can connect with of people going through the same thing and other family members and carers who are supporting their loved one and getting connection and support from there so it's less isolating. They also talk about oh, uh, the different caring styles, and they use animal metaphors. And I'm not going to go into these metaphors, but the ones in white are kind of ways that people cope that might be not so helpful, and the ones in black are the ones that people cope that might be so helpful. And even though these are used in the eating disorder world, I found them really helpful to think about your own style and how you relate when you get anxious. So these are ways of when things are really, really difficult and everything seems to be um, really kind of heightened in that moment. What do you tend to do? Are you the ostrich or are you the dolphin? And that can be a really nice way of thinking about, oh gosh, I've gone into that, and kind of recognizing what you're pulled to do and helping think about what you would like to do as an alternative in response to your loved one's distress. So I think it really fits well with any person when you're supporting anyone who gets really, really distressed and may engage in risky behaviors that will really, really distress you. So I did a bit of research in preparation for this about, well, what studies do we have on interventions for family members for people with an eating and a personality disorder? And I only found two, and they were both in Spain, and I'm not sure why they were both in Spain. But um, uh, one of them was based on DBT and DBT for families. Um, and the other one, interesting, was based on an adaptation of the Family Connections Protocol. So I didn't expect to find that in my research, but I thought that was a really interesting thing, since I'm coming here to present to you from Family Connections. And the results of that one are out. It's an RCT, a randomized control trial. So it's really going to be a really great study when the results are out of how effective an adaptation of the Family Connections Protocol so that it can support people with eating disorders and personality disorders is. So I think that's something definitely to think about in the future. Um, and so I guess what we do to support as clinicians to support family members and other supports of the people that we work with is we involve them from the start. In the initial assessment, we provide a lot of psychoeducation. We have a lot of conversations about specific topics, whether that's meal support or safety planning. We have we involve them in parent sessions or family sessions, and we invite them to groups and get them involved in kind of some of those support groups so that they have connections with other family members, as well as learning more about eating disorders and personality disorders. And a really big focus of our work as well is to think about helping people to have helpful ways of communicating to their loved one, because particularly when they're distressed as family members, understandably, it can be harder to kind of provide support in a helpful way. And so we kind of support people to do that. We also do a lot of work with family members, helping them think about balancing the risk of supporting their loved one. How can you, but also getting them to become more competent and confident in their own abilities, because what we don't want to do is make that person feel like they're not capable. So even whether it's around meal times or safety planning, we need to support the family to help them support the young person to empower them. And we also kind of explore the family members' relationships with food, eating, body shape, weight, and appearance, because because we all get affected by the messages of society, it's really important to think about what messages you're inadvertently giving to your loved ones. So you might be encouraging your loved one to eat 6 times a day, but you might not be, because you're on a diet that says that you need to um, not eat for long periods of times, intermittent fasting or things like that. And what kind of message is that saying about your body and your and what and its appearance and how much you value that? So I guess it's a challenging conversation to have, but it's really important for us to also reflect on our own relationship with appearance when we're working with people with an eating disorder. And that's it. And I think I managed to get that in about an hour. So I'm hoping that that leaves us some time to have questions. And if anyone wants me to elaborate on anything, I can.
Yeah,
So,
that was awesome. Rim, I was going to say, while you still got uh, the slide up, I would personally, I would love to get a little bit more elaboration on those, the parenting styles, the ostriches and kangaroos, and
okay.
that was fascinating. Or it was intriguing.
I didn't know if I had enough time, so I didn't want to
Mm,
use that time. But I guess so. Yeah, I really, really, when I first learned about these, thought they were really helpful, and I use them in my work a lot. And I use them to think about my own ways of relating. So the ostrich is when the ostrich gets overwhelmed, there's a tendency to bury their head in the sand. And the risk of that is that the loved one might feel unloved or ignored, or it might be that they're modeling, not intentionally, but an avoidant way of coping. Like if you have strong emotions, you need to avoid, which can be, help the person that might say to the person they're working with, well, I need to avoid my emotions too. The jellyfish is also, when they're overwhelmed, they tend to regulate either by getting, sad or mad. So um, uh, their distress is really transparent, and that can be really hard for the person that they're caring for, because they might see, oh gosh, I've really upset them, or I'm worried if I do this, they might get upset. And so it very much means that the person with the eating disorder and personality disorder might feel like they have to really care for their carer and be really avoidant of
mm,
talking about them. The other thing that the jellyfish has is that poisonous thing, and sometimes that's when the jellyfish loses their temper. And that can be really difficult too. So thinking of ways that you can manage your emotions so that you don't get to that point of letting that sting out. Um, the rhino manages their stress by trying to convince and persuade and push, and uh, so gets into lots of arguments and gets into lots of battles with trying to force their way of thinking along, which understandably, if you're really worried about someone and you've got all of these ideas of what might help, you might get stuck into doing that. But actually, what that does is often push the other person away or gets them into arguing back too, and can cause lots of fights, which makes everyone miserable. The kangaroo, which I really liked because that had an Australian theme, tends to like want to really protect their loved one, put them in a pouch, and not let them get upset or angry. But unfortunately, when you're trying to overcome some of these things, you will need to experience. So someone with a personality disorder might need to learn to manage their distress, and that means they're going to have to experience distress. And the same with an eating disorder. Eating can be really distressing, but they need to eat. So if you try and stop your loved one from experiencing any distress by being really protective of them, which is understandable, but it's not helping them to recover. Um,
mm.
and it's not helping them learn how they can manage these life's challenges. Um, oh, sorry, I don't know why that popped up. Um, the terrier is someone who is a bit snappy and constantly going, come on, come on, come on, you need to do this, you need to do this, and trying to cajole or nag or just anything they can do. So constantly, giving instructions and things like that, which can be really wearing and potentially irritating to the loved one and lead to arguments, or them just kind of shutting down and avoiding and closing the door in their room and not wanting to engage. So the alternatives are the dolphin, who is always present and there to guide, and kind of is caring and in control, but more of an inner guiding alongside, swimming alongside. And if ever the The baby dolphin swims away out of the pod that comes along and pushes them back in, but in a little nudge to keep them back in the safe place. So if there's any risky behavior, they might swim a bit more, but then they swim back along and let the others and let that person kind of swim for themselves. The Saint Bernard is the kind of um, compassionate and consistent support that's always there and reliable and dependable, but kind of has a really calm, laid back approach, um, and kind of allows that person to have hope that they can do those things, but will always be there and reliable and dependable. Um, and the herd of elephants is kind of what they're trying to suggest is that it's actually very hard to do any of this on your own, and you need a community and you need to collaborate. You need to collaborate with your loved one. You need to collaborate with um, your supports. You need to collaborate with their treating team. That actually, it's not just one person. So it's the other metaphor I like to think of is it takes a village to support. And so that's a really nice one to remember that you don't have to do this on your own. You need to find
Mm.
your herd and get that support from them. So
Right.
hopefully that's a
Thank
quick
you. That
overview. And part of the program that I was talking about is getting really people to think about when they might be different animals and why and what the triggers are and things like that.
I'm just at that stage where I'm caring for elderly parents or starting to care for elderly parents, and I just saw the rhino and went, "Oh,
Yeah,
there I am."
yeah,
You know,
yeah.
so I'll bear it in mind. Thank you. You've already helped one person today. So with the other questions, I think we had another little sort of quick question around what is mantra and what is FPT.
Oh, so
Yeah, yeah,
mantra is the Maudsley adult Maudsley anorexia nervosa treatment. Uh, Something it's the so FTAN, the family-based treatments for adolescents, was developed in the UK in the Maudsley Hospital, and mantra is the Maudsley model for adults. And it's the difference from CBT is it's got much more of an interpersonal focus. So it's tended to be used for more severe people where CBT hasn't been so effective, and there's a much more interpersonal component to it, which I think really reflects people with more personality disorder features in there. So
Mhm.
there are some providers in Australia, but it's not that common in Australia. So I guess we're really keen to see that develop, and there's evidence for that. Um, and it makes sense that they would have developed the family-based therapy treatments for adolescents and then gone on to develop a more family or interpersonal. So it's not just for family; it could be partners, care, focus for more severe eating disorders in adults. FBT is focal psychotherapy, which is a kind of a brief, very specific type of psychotherapy that has been shown to have some evidence. Again, I'm not really aware of many people in Australia who do that. It's something that's much more common in the UK. Um,
Mm.
Things like DBTRO and things like that are much more building up an evidence base in Australia. But these are options. And the psychodynamic therapy, again, has a much more interpersonal focus. And both mantra and FBT are considered second line treatments when CBT hasn't been so effective.
Mhm.
So which might be more helpful for people with comorbid issues. Although we haven't
Sure.
got research in that, I'm just hypothesizing that if there's interpersonal issues, they might be better.
Yeah. And so, especially given that myth, that such a persistent myth around you can't diagnose personality disorders until someone's 18. What is the process for for assessing and diagnosing a personality disorder?
Um, so I can speak for our service, which is, people who are, we do a really thorough assessment, and there's a lot of training being done in Victoria and Australia around this assessment for services, child and youth mental health services. But I can really appreciate that sometimes people aren't able to access this. I would encourage them to, even if you Google hype and that there's a lot of research out there that shows you, and take it to your clinicians and get them to have a look at some of the research and the current evidence. It actually doesn't say in the DSM anymore that you have to be over 18. So
Mm.
I think that it's a really hard myth to that, but I think, going and being persistent about that, actually, you really would like your person to have an assessment about this. Um, we do a developmental assessment. We take into account people's history across their lifespan. We look at other disorders like depression and how they may be affected. We also take a kind of look for evidence for a 2-year history, because we're trying to find things out of the normative ups and downs of being a teenager. Um, and we do that because we actually want to be really careful. We're not just willy-nilly saying people have personality disorders when they're 15. And sometimes what we'll say is you might have some of the features of a personality disorder. You haven't
Mm.
got a personality disorder, but you're on there. Yep, that's right. Someone said that you can be diagnosed from the age of 12. So the myth is there. Remember, some clinicians like me, we trained a long time ago when we were trained that you would be over 18, and it's about updating their knowledge. And I guess some people are better at updating their knowledge than others, or may have access to training that other people have. But I guess I would be really kind of assertive about this idea of it's really important for my young person to get treatment early. That's what the evidence shows. So please, can you do an assessment? I can.
But what is the evidence showing in terms of the difference between somebody who's diagnosed with a personality disorder at say 14 versus 19 or 24?
I'm not. I guess I'm not sure of what the research shows there, but what we know is that um, in the past, people weren't getting treatment, or getting treatment when they were much older, and there was a lot of um, evidence of their functioning being really impaired and long standing. Yeah.
Mm.
So the younger that we treat people, we put them back on the right path for getting back to school, having healthier relationships, reducing their self-harm, reducing their improving their ability, their sense of self, so that they can actually continue to engage in life the way that we want young people to, go to school, get an education, working life, have healthy relationships. But people who haven't had that opportunity to work on those issues are getting into adulthood and unfortunately having really difficult relationships, which kind of perpetuate this idea that there's something wrong with them, or they're not good enough, and I'm not that. They might drop out of education and employment. They might start engaging in substance use. It really can
They're
be a
accumulating traumas
trauma.
effectively, aren't
Yes.
they?
Yeah.
Yeah.
And what we've shown is that treatment can help prevent all of that,
Yeah.
or and
Awesome.
reduce that and slow it down. So that's what's really important. And I guess one of the things that Andrew Channon would say, and I've worked a lot with him and I've heard him speak a lot, is, we don't wait till people have got stage 4 cancer to treat cancer. Yep.
Mm.
Um, People might have
Amen.
been, yeah, and that's what we're saying with personality disorders. So you might not, we're not necessarily diagnosing a lot of 12-year-olds, but we're saying you've got features of it, and we're saying you need to start having, we can give you treatment to support that. So they might not have a full threshold personality disorder, but they've got features of personality disorder that warrant treatment.
Yep. Great.
Mm.
Um, okay. So another question is, um, what are the factors that make someone at risk of developing an eating disorder?
One
I
of the
mean, that's a
biggest,
long question. Yeah.
yeah, one of the biggest factors is um, dieting, or significant weight loss for another reason, like maybe you get really ill, you have gastro. Yeah. We know that. So it's really important for us to think about people who are going on diets. Yep. And not and be really careful about that. And I guess that was going back to the reflecting on how much we all value certain appearances and things like that. We know that people who have been bullied, who people as particularly about their appearance, but doesn't have to be about their appearance. People who have challenges in their relationships generally are more likely to develop it. We know people who have a strong focus on their bodies, so people in sports professions, dancers, things like that might be more vulnerable. Women are more vulnerable, young people are more vulnerable. So we've got vulnerabilities are pretty big. And that's probably reflecting why there's a rise and increase in the rate of eating disorders. And I will say that there's also a significant increase in men. And some of the diagnostic criteria make it harder for us to diagnose men, like anorexia. But so I guess we do think that men are becoming more at risk. But at the moment, you're more likely to have an eating disorder if you're a woman. But
Mm.
and the
Um,
transgender community, as I mentioned, is also really, really
mm,
vulnerable.
well, that's a lot about not letting their body become what they don't want it to be,
It can be,
isn't it?
yes. Or
Mm,
just the kind of, and also a sense of not really liking themselves for, yeah.
mm. What is the difference between compulsive eating and binge eating disorder?
Um, when we define a binge, it's discrete short periods of time and feel a loss of control and eating an amount of food that is not considered within the norm of whereas compulsive eating is a much more ongoing thing of just not being able to stop eating. Yeah, so binge eating is kind of quite specific, and people might engage in binges 3 or 4 times a day, but there's usually a start and an end, and it can feel very out of control
Hmm.
in that moment.
Yeah. Um, we've got sort of a general question that was emailed in around AFID, FIRD, is that how
ARFID, yeah.
AFID?
Um,
Yes. That seems like it's a separated out from the other eating disorders, and the way that you handle that. What are the sort of the differences apart from what you've already told us?
Yeah, I mean, CBT is still really effective for ARFID. I think one of the differences is it's often much more of an chronic thing that started in early childhood because it's
Mm,
often used due to sensory preferences or a lack of interest. Um, it can morph into something like anorexia when young people hit adolescence and they might start having body image concerns. But the big difference is that people with ARFID don't have body image concerns. It's less about
mm,
a fear of how they look and more about a fear of the actual food. And but in anorexia and in binge eating and bulimia, people do talk about fear foods, but it's the food is feared because of it might make them gain weight rather than the food is feared for itself. Like if I eat this, I might get really sick, or if I eat this, this texture will make me feel unwell, that kind of thing, if that makes sense.
mhm.
Mm.
Um, okay. So I've just got a question that's a little bit too specific. Um, okay. This is a little bit specific too, but we've got a question about supporting someone with type 1 diabetes, BPD, and disordered eating, and who, might use non-compliance of their diabetic management as a form of self-harm.
Yeah,
Do you ever see that sort of thing? I mean, you
we
said there's a lot
do.
of comorbidities.
We do, and it is a really challenging one. And I guess, I'm not going to give anything specific advice, but I think that reflects um, the how the relationship between the different disorders. And so in this instance, if you didn't, um, it's really important to work on the personality disorder and consider the eating disorder as a coping strategy to manage. But if you don't tackle the eating disorder as well and support regular eating, there's a real risk. Yeah. So that's why in that section that I talked about that actually we can't ignore the eating disorder and just treat the personality disorder because the risk for that person, particularly someone with type 1 diabetes. But if you just focus on the eating disorder, you're kind of not really recognizing that it serves a function with the personality disorder.
Mm,
So this is why treatment that addresses both is really important.
yeah.
Yeah.
Just a comment there that I've worked with people with BPD, but every time there's been a comorbid eating disorder, I've just gone, okay, I need to pass you on because it
Yes,
is very complicated and
it
it does
is.
involve the whole family, and it's requires a lot more support, I think, than what one-on-one psychotherapy can provide.
Yes, and I'm very lucky to work in a multidisciplinary team and have the support of dietitians and psychiatrists. And I think sometimes with those more complex presentations, that is really what's needed. But I know that access to that across the country is varies. But similarly, lots of eating disorder services will exclude people with a personality disorder because of their level of risk and self-harm and things like that. So it's really um, I would say people with personality disorders and eating disorders are some of the most um, important people for us to work with because of how complex and difficult their lives are and how much suffering they're experiencing and their families are experiencing. Um, yeah. So I'm ho
Yeah.
really hoping that we get better at it.
There's a question that was also sent in about, what physical symptoms to look out for, which I think you sort of touched on, but I'm wondering, is there a priority around, because a lot of, as you were saying, a lot of eating disorders can be present without a change in weight.
Yes.
So is it more about making sure that you all eat together and that you notice how much they're eating during the day, or
Yeah. I
what's the
mean,
sort of thing that you would do there?
I definitely think, weight is a metric, but it's not the only metric. So, when we're doing physical observations, we're checking how heart's functioning, we're checking blood tests, things like that. So they're really important. So, but what you will observe is, yeah, if someone is changing their relationship to food and meal times, if your family member used to eat with you all the time and suddenly skipping lots of meal, question that. If they're talking about wanting to be on diets or losing weight or getting a real sense of, have a think about that. And if you're noticing then other symptoms like they might be more tired or they might be more irritable than out of the norm, things like that, they're things to notice. But it can be really hard because it's not just about weight loss. Another thing you might notice is after every meal they go to the toilet immediately, and that might be a sign that they're purging or something like that. So these are things you might notice them buying lots of over-the-counter things and getting into buying supplements for their health and things like that, and be wondering, are we going down the kind of diet pills, things like that, or just conversations around is that healthy? How many nutrients is that? Is, kind of like a dissecting of food in the kind of which, as I mentioned earlier, is kind of hard for us to really sometimes recognize because it's become a normalized thing in society, but actually it's not that normal
Mm,
you know.
yeah. Um, so I think that there is a question in the uh, chat that sort of goes into, I think, in very broad, that asks specifically about their person and their struggles, rather than ask that question, because you can't sort of advise on treatment for someone that you don't know and can't see. And I think you've covered all the general things. What would your general advice be around, if you suspect that a personality disorder and an eating disorder is present, how do you find a treatment team? What are the sort of things that you should be looking for? Should you be
Um,
looking for a team-based approach, for example, or
I definitely would be looking for a team-based approach. You want someone who kind of is willing to support someone around their eating disorder, but also kind of understands um, risk to self, suicidal risk, self-harm risk, and things like that, and is willing to kind of support that. Because one of the things I mentioned as well is that sometimes it can be a bit of an up and down, as one thing gets worse, the other thing gets better, and so having a team that can kind of sit with some of that while you're going through the intervention is really important. And that generally does mean it needs to be a team, particularly at the more risky end, whether that's medical risk or physical risk. So ideally, even if you can't find a team, I'd be looking at, at least having a, 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 a mental health clinician, a psychologist, or a OT, a social worker who's got experience in working with eating disorders, experience with working personality disorders, linking in with a dietitian and ideally, a psychiatrist to kind of support as well.
yeah. Um, so we've also had some questions about medications, like the impact of, some medications cause people to gain weight, so then they don't want to take those medications. And then you have obviously the ADHD stimulant medications can suppress appetite.
Yes. So I
Um,
can't give any direct advice about medications. I'm not a medical doctor, but I will say these are really common issues for us. Um, if people are being prescribed antipsychotics, there are many of them that do have that side effect. So I think it's about being really honest with this person prescribing it, that I'm really concerned about this side effect. I'm worried about weight gain. This is affecting me, and having that conversation early, and so that you can negotiate, because some medications have more side effects like that than others. So if you're honest and saying this is a problem for me, or if your loved one is saying this, then at least that gives the prescriber some chance to discuss it. Also, kind of being referred to a dietitian to get some support around that. Or an exercise physiologist, because actually one of the things, it's not just about it does sometimes increase appetite, but it also increases sedation, so people get less active. So it's the combination. So, if people can get supported to have engage in more activity and be supported around that too. So I think we would never say don't take the medications, but I think it's fair to say this is a side effect that's bothering me, and can we talk about it more, and think about the options for me. With ADHD meds, yes, some of them do reduce appetite. So again, that's a really important thing to talk about. Again, get some support. I mean, how can I maintain a regular amount of eating even though my appetite, and so having some structure around that. Um, uh, Often those initial appetite suppressant effects what do wear off. So it's maybe thinking about it in the short term, and then how we can support you, because people's appetites generally do start getting back to normal. But there are, and again, it's about discussing it with the person prescribing and saying, this is bothering me, or I've got some worries about my body image, and reducing my appetite might be a bit of a trigger, because there are some non-stimulant based ADHD meds available. Not that I'm but
yeah.
talking to this person prescribing about that is a really important thing, to be really honest about what side effects are bothering you or potentially triggering um, other problems that they might not know you have.
Yeah. Um, we've had some questions around resources. I just want to let people know that in the chat, I've put in a link to BPD Foundation, which is another not-for-profit that specialises in this area. And they have a little map with a list of, by state, a list of all the government and not-for-profit services that work in this area. And I suspect that the Butterfly Foundation's also got a similar thing. So they're two not-for-profit organisations that work in that space. We also, our website is bpdaustralia.org. I can't remember if there's a .au at the end. You'll get there. And we have a lot of resources and on our website, and some lots of different webinars. This is the first one that I've been involved with around eating disorders, but yeah, we've got some fantastic webinars up there, so I really encourage people to take a look. Just a question about the Butterfly Foundation. No, the Butterfly Foundation is an eating disorder foundation. So
We haven't got one that does both yet.
no, well, people are complex, aren't they?
Yes.
And therefore the treatment's going to be complex too.
Yeah.
And tailored. So uh, okay. Yeah, so again, there are questions around access to help. Yeah, I think just having a look online. Sorry, what's the new name of Origin? It's almost one.
PIMS.
You had this
Well,
simple name.
it did. Well, though we always had to spell it because we're not an electricity company, but
Yeah.
that we cover the northwest region of Melbourne, and we're Parkville Youth Mental Health and Wellbeing Service. Uh, there are probably links from Origin to PIMS at the moment, but Origin still exists, and they still do all that youth mental health research, including in personality disorder, but psychosis and other things, and they do a lot of policy for youth mental health. So there's still an organization that exists. We are the clinical end that offer the services to this area, and we're a slightly different name.
Yeah. Great.
But we'll still
Okay.
be
Yeah.
working with them closely. We're like brother and sister.
Yeah. Yeah. So I just encourage people to have a look at the BPD Foundation website, which will link into for your state. And I guess people can, it's not nothing about if you're living in this land of eating disorders and personality disorders is easy, but, even just enlisting your GP and saying, I need a team's approach, I need people to talk to each other, and, making your own team. And if people aren't prepared to talk to each other, find someone who is, would be
Yes.
my unsolicited advice.
Yeah.
Yeah.
And one of the really great things for people with a more moderate to severe eating disorder is that there is under Medicare something called an eating disorder plan,
Oh,
where
great.
people can access up to 40 sessions of Medicare psychological therapy and 20 sessions of dietetic support a year, as long as they have a referral from a GP and a psychiatrist. So it's a real extension to the general Medicare, 10 sessions. There are criteria for that, but that's a national thing. And people would be eligible for that if they have a moderate to severe eating disorder. And, hopefully that person would also be able to support, if they get the right clinician, be able to support them around their eating disorder and their personality disorder symptoms.
Fantastic.
Yeah.
I was unaware of that. That's great to know.
Um,
Well, we're coming to the end of our presentation. Reem, that was really fantastic. Thank you so much for your time and for looking into the latest research. And it's very validating for us to know that the latest research was about family connections.
I thought that was great.
Yeah, exactly. Yeah, thanks again for raising awareness. And anybody that's watching this now or in the future on our YouTube channel, send the link to your health professionals, because there are some great myth busting happening in here that I think we need to get out there. So yeah, once again, thank you so much for a really interesting and informative, and I think for a lot of people, supportive presentation.
Great. Well, thank you. Thanks for inviting me. And yeah, good luck, and I hope it all goes well.
Yeah, great. Okay,
Thanks. Thank you.
thanks.
Bye.
I'm going to end the recording.